Hello guys, so next in the series of the lectures is X-rays in the surgery. So the first and most important thing is how to read an X-ray. So you have to look for the bones. Bones will block the radiation and appear white. You have to see the muscle, fluid, fat. So some radiation pass through them and they appear gray. And there are some breaks, that is fracture. Radiation passes completely through them and they appear black. So the basics is plain or contrast radiograph of chest or abdomen or KV system are done usually in surgery. So chest in AP view, the spine is more prominent, and PA view, lung fields are more prominent. In abdomen, erect airflow levels are seen, or in supine, dilated ball loops are, and edema is more clearly visible. So in plain X-ray measures the reason and the structures which are visible and normal, then you have to tell about the abnormal findings. So always start with the normal things. Contrast, when used, tell the type of contrast, that is the radiograph which is used. So barium, ERCP, IVP, etc. You have to mention that. So this is the simple plain X-ray. In this you can see it is showing the spines which are prominent, the clavicle, the rib cage, the bronchovascular markings. These are the bronchovascular markings, the heart shadow, and the costophrenic angle. So this is very important to see for effusion and also hydropneumothorax etc. So plain X-ray chest and upper abdomen. Let us see it is plain X-ray chest and it was inspiratory film. So anterior ends of the 6 and 7 ribs reach the mid-clavicular line when it is inspiratory film. You can see this. So this is the first rib, this is the second, this is the third, this is the fourth, this is the fifth, this is the sixth. So sixth and seventh, and these are, if you can trace vertically, reaching the mid-clavicular point. So it is showing the bilateral lung fields, scapular shadow, heart shadow, both clavicles, rib cage, bronchovascular markings, both lobes of the diaphragm were visible in this. So the chest AP view is which rays pass from the front, but the plate is at the back, so the posterior surfaces are more prominent. I'm talking about AP view. In PA view, the rays pass from the back, but the plate is at the front. In this, lung, heart shadow are more prominent. So this is the example: the patient's standing. In PA view, the plate is in the front and the rays are passing from behind. And in this AP view, the plate is in the back and the rays are passing from the front. So you can see this is in contact with the patient surface. So the posterior aspects of the body is more prominently visualized. So this is the X-ray of pneumothorax. You can see the lung parenchyma is collapsed, and this is the black area showing the air. So that is the pneumothorax. So types are open and the closed. In open, the large one which is communicating to the atmosphere is there, but it is also in case of closed wound. The causes can be trauma or spontaneous. The spontaneous causes are tubercular, emphysematous, bulla, rupture, or idiopathic. The treatment is oxygenation, analgesics, and IV fluids are most important. In open one, first close the wound, then chest tube from different side can be tried. Close one, chest tube insertion is tried first. In tension pneumothorax, needle puncture, second intercostal space in mid-clavicular line using a wide bore needle is very important, followed by chest tube. So the chest tube picture can also be there in the examination. So this is the X-ray. Here there was a hydropneumothorax and chest tube was inserted. So you can identify the chest tube here. Indications for chest tube insertion are done to expand the collapsed lung due to pneumothorax, hemothorax, pleural effusion, or hemothoracis. It is inserted in the fifth intercostal space in the anterior axillary line. You are well aware of that point. And drainage is done in the water seal drainage bag. Lungs have negative pressure, that is why water seal is required, otherwise air would be sucked in and it will not help. The rib fracture is also very important and the common radiograph which you find in surgery examinations. So you can see this rib is fractured, this is fractured, this is fractured, fractured. So the flail chest is one of the severe kind of rib fracture. It is defined at 2 or more reps. It can be 3 or more reps also, depending on which book you are studying. So it is defined as 2 or more reps fractured at 2 or more points, and that segment showed paradoxical respiration during the paradoxical movement during respiration. So this is very important thing which should be remembered. It can be minor frail chest. It is in which a small segment is involved and no ABG alteration is there. In major flail chest, large and ABG alteration is there. The treatment is obviously analgesics, ABG monitoring, oxygen if required, and chest physiotherapy plus chest tube if there is pneumothorax effusion etc. And intubation and positive pressure ventilation may be required in some cases. So the pleural effusion is also an X-ray. So this is a patient X-ray which is showing pleural effusion. How will you identify? So there will be blunting of costophrenic angles on the side where there is an effusion. So it can be exudative or transudative. The causes include malignant, tuberculosis, traumatic, subphrenic abscess, infection leading to empyema. Treatment is treat the cause, aspiration when it is small, chest tube placement if lung function compromise or empyemothorax is there. Hydropneumothorax is characteristically defined by the air fluid level. So you can see this is the air and this is the fluid. It is showing the air fluid level. So air as well as fluid is present. So there is air fluid level. Fluid can be serous or pus or the blood depending on the cause. The treatment is chest tube insertion, antibiotics, chest physiotherapy. You have to treat the cause if not due to trauma obviously. Cannonball mets are also the X-ray you get. So these are metastasis from the uh, other primary. That can be many reasons from where the chest mets can come. So these are rounded cannonball like opacities which are seen on the X-ray. The causes are metastasis, histoplasmosis, aspergillosis, that is fungal infection, sarcoidosis, rheumatoid nodules also cause this. The primary sites leading to lung mets are the mnemonic I have formed as the lungs. So it may be difficult to remember, but yeah, definitely THE, the it is thyroid, L is lungs, and the breast also because they are involved in the same area. You can say if you see from outside. U is uterus, ovary, testis, N is nephron, that is kidney, G is gastric or the intestinal malignancy can lead to this, and S is the soft tissue sarcoma leading to lung metastasis. The abdominal X-rays are also very important. Abdominal X-ray, erect X-ray will show air fluid levels, and the supine X-ray will show dilated volutes or the edema. Air fluid levels are, you can see like this are the air fluid levels. These then same obstruction picture can be shown, and these are the dilated volutes. So you can see these are the valvulae convenientes. So the causes are obstruction. It may be due to tubercular stricture, intussusception, malignancy, postoperative adhesions, obstructed hernia, intestinal or sigmoid, volvulus, that is sigmoid or cecal. Central loops are small. They show step ladder pattern. Jejunum show presence of valvulae convenientes. These lobes are complete, as you can see. These are valvuloconvenientes. So yeah, convenientes. These are complete. So peripheral loops are large. Oh, you can say when the loops are peripheral, you can say it is a large bowel, and these show hostrations and which are incomplete. So duodenal and terminal ileal loops are normal. So if you see two air fluid levels in an X-ray and these are corresponding to duodenal and terminal ileal loops, you can say this is a normal finding. The air under diaphragm is always abnormal. So this is the air under both domes of the diaphragm, and it is causing the things which are causing air under diaphragm are perforation in GI tract, that is stomach, duodenum, small intestine, large intestine or the rectum, penetrating injury in the abdomen causing peritoneal breach or hollow visceral perforation, abdominal surgeries, open or laparoscopy can cause this, tubal insufflation test can cause this, bullet injury in abdomen can cause this, appendicular perforation usually does not have the gas under diaphragm. This is very important, you should remember. Sigmoid volvulus is again an important X-ray which can be shown. So this is outer layer, inner wall. So it is coffee bean sign. You can say the causes are long redundant sigmoid colon, long pelvic mesocolon, bands, long sigmoid with narrow attachment to the mesocolon. The volvulus is defined as abnormal rotation of a bowel segment around narrow mesentery leading to obstruction of the gangrene. Ileosigmoid knotting is known as the you can say compound volvulus, and the loop extends from pelvis to the upper abdomen. In the volvulus, you can say inner septa is formed by the inner walls of the sigmoid colon. Oh, it is omega shaped. You have seen the picture. Doll-Froment sign is there, in which you can see the three lines, two outer walls and one inner wall converge in the pelvis. So let us see again. So these are the two outer walls and one inner wall, and all of them are converging in the pelvis. This is the important finding. So KUV, in KUV, it is a stone. This is very characteristically seen in the cranial X-rays. So how will you differentiate from a gallstone? So you have to take lateral view, and when you see it is anterior to the vertebral column, it is gallbladder stone, and it is posterior to the vertebral column, it is you can say kidney stone, or also you can get the ultrasound done. So to completely get clearance about the location of the stone. So 10% of the gallstones are radio opaque, and the 90% of the kidney stones are radio opaque. Radio opaque renal stones examples are oxalate, phosphate, cysteine, xanthine. Radiolucent renal stones examples are uric acid and the uric stones. So management is when the stone is less than 0.5 millimeter, medical management is required up to 10 millimeter. Medical management can be tried up to 2 centimeter. ESWL is done more than 2 centimeter. PCNL or open depending on the facility and expertise. And uric stones, ESWL, URS and open surgery. These are the options. So this is a picture of double J stent. So double J stent can be kept for up to 6 months. Lower portion is urinary bladder, upper portion the renal pelvis. Indications are small kidney stones less than 1 centimeter that can pass easily after passing the stent. Before ESWL to facilitate the expulsion of the stone, to keep ureter patent in a retroperitoneal fibrosis, and after surgery of renal pelvis or ureter to prevent fibrosis and keep both patent. So thank you so much. Will be next.